Hi, I'm Jenna Guerin. Today's date is September 20th, 2020, and I'm going to be presenting my case 4 studies. So for case 1, the most useful test is going to be plasma glutamine levels. So serum fatty acid levels would only really help to determine if the patient was having a beta oxidation disorder. A deficiency in beta oxidation is going to lead to an increase in levels of serum fatty acids, but serum fatty acid levels would not be affected by a urea cycle disorder. Additionally, urinary acid testing would not help in diagnosing urea cycle disorders. If the values are abnormal, it may be suggestive of fatty acid oxidation defects, but urea cycle disorders tend to have urinary acid levels that are normal. And as far as glucose goes, both may be hypoglycemic. So for plasma um, glutamine levels are increased in all urea cycle defects, but this is not true for beta oxidation defects, making it the right choice to distinguish a beta oxidation defect from a urea cycle disorder. So we can kind of see this is taken right from the PowerPoint, but we can kind of see why that would happen. Glutamine here is transaminated into glutamate, and then from there it can enter the urea cycle as ammonia. But if the urea cycle has a defect in it, this is all going to become backed up, leading to a backup of glutamine. So when your orotic acid and blood ammonia levels are elevated and plasma citrulline is normal, the most likely enzyme defect is going to be a deficiency in the ornithine transcarbamylase, or OTC. And OTC is responsible for the conversion of carbamyl phosphate and ornithine into citrulline. So we can see that over in this diagram. This is OTC, and we have ornithine here and carbamyl phosphate here going into citrulline. So deficiency here is going to cause an increase in orotic acid and ammonia. Due to the OTC deficiency, carbamyl phosphate is accumulating in the mitochondrial matrix to a point where it's going to diffuse out into the cytoplasm. Once it diffuses out into the cytoplasm, it's going to be used for synthesis of pyrimidine. And one of the intermediates of pyrimidine synthesis is orotic acid. And when there's a lot of it, it's going to be excreted in the urine, giving that lab result. Then also due to the buildup of carbamyl phosphate, there is going to be less clearance of ammonia from the blood, leading to an increase of ammonia there. It is least likely that there is going to be a deficiency in carbamyl phosphate synthetase 1. This is least likely because if there was a deficiency here, urine orotate would be low. So blood ammonia levels would still be elevated, but the orotate levels would be low in the urine because carbamyl phosphate is low, so it's not going to be diffusing out into the cytoplasm. Also, free ammonia is going to accumulate because it's not able to be synthesized into carbamyl phosphate. So the least likely deficiency is going to be a deficiency in carbamyl phosphate synthetase 1. So then I looked at case number 2, and in case number 2, when phenylketonuria is present, tyrosine becomes essential. Normally, phenylalanine is hydroxylated to tyrosine by phenylalanine hydrolase and the cofactor B4. We can see that here we have phenylalanine, this is B4 over here, and it's going to turn to tyrosine using phenylalanine hydroxylase. So deficiency in any of these is going to lead to a buildup of phenylalanine and no hydroxylation to tyrosine. Tyrosine, therefore, now becomes essential since there is no production of this amino acid within the body. Presentation of phenylketonuria may be caused by a mutation in PAH, or phenylalanine hydrolase gene, so there's going to be a deficiency in this enzyme. And this is going to cause phenylalanine to not be hydroxylated to tyrosine and therefore cause a buildup of phenylalanine. And this is problematic because phenylalanine is toxic to the brain, and when phenylalanine is in excess in the blood, it will saturate large neutral amino acid transporters to cross the blood-brain barrier. When there's too much phenylalanine on these transporters, the levels of other large neutral amino acids are decreased. And these other acids that are no longer present are needed for protein and neurotransmitter synthesis. So that leads to the development of the brain being hindered. Then we can look at this graph that was provided. By looking at the graph, it can be seen that after B4, which is the cofactor, patient A had an increase in phenylalanine levels, but patient B had a large decrease in phenylalanine levels. So as previously stated, phenylalanine hydrolase needs the cofactor B4. If B4 is given and levels decrease, it appears the patient has a deficiency within B4 itself and not the enzyme hydroxylating phenylalanine to tyrosine. This is seen in patient B. The levels of phenylalanine dropped, meaning it is being removed from the blood and hydroxylated into tyrosine. In patient A, since supplementation with B4 did not change the levels, the deficiency is going to be in PAH, or phenylalanine hydrolase. Here, PAH is not using the BH4 even during supplementation to cause phenylalanine to be hydroxylated into tyrosine.